Welcome to today's deep dive. I'm really glad you could join us because we're looking at something that, well, it affects so many people, but is still incredibly misunderstood.
Yeah, it really is. It's one of those topics that forces us to completely rethink how we view medicine.
Exactly. Usually when you break a bone, it's binary, right? The X-ray shows a clean, jagged white line.
Right, very clear cut.
Yeah, the doctor points at the screen, says, there's the fracture, and you get a cast. It's a very comforting, almost engineering-like precision.
But when you step into the world of neurodevelopment and chronic pain conditions, that X-ray machine is just, well, it's utterly useless.
Totally useless. You're suddenly navigating this diagnostic landscape where the most devastating injuries don't leave a visible mark at all.
Yeah, and it's a complete shift from a structural mindset to a functional one. We are so conditioned to look for tissue damage.
Right, something tangible.
Exactly, something we can cut out or put in a splint. When a patient presents with systemic, debilitating symptoms but entirely normal imaging, the traditional biomedical model essentially just short circuits.
Which perfectly sets up our source material for today. We're looking at a fascinating set of clinical notes and pharmacological profiles compiled under what I think is a surprisingly ironic title.
Oh, the title is incredibly ironic.
Right. It's literally titled Comfort. Because this document is fundamentally about two very inherently uncomfortable things.
Definitely.
First, the incredibly misunderstood chronic pain condition of fibromyalgia, and second, the intense, sometimes genuinely bizarre pharmacological treatments used to chase that elusive comfort.
Like Ambien.
Yes, exactly, like zolpidem tartrate or Ambien.
The irony of that title really hits hard when you dig into the clinical reality. I mean, we're looking at a disease defined by a nervous system that refuses to rest.
Just constantly firing.
Right, paired with these heavy-hitting medications designed to forcefully override that entire system.
So, for you listening, think of this deep dive as a journey through a misfiring nervous system. We'll unpack how the body's pain alarm system breaks down, how doctors track an invisible illness, and why the cure for the resulting insomnia might have you, like, driving a car while fast asleep.
It's a wild ride.
It really is. So, to understand why someone would subject their brain to that kind of chemical override, we have to start with the condition itself. Let's talk about the origins of fibromyalgia,
Well, the document traces the recognition of fibromyalgia back to the 1970s.
which is pretty recent, right?
In the grand scheme of medicine, absolutely, it's very recent. And for decades, it was just lumped in with autoimmune diseases.
Oh, okay.
Yeah, physicians saw patients with widespread musculoskeletal pain, profound fatigue, joint stiffness, and they naturally assumed it was a rheumatologic issue.
Like lupus or something.
Exactly, like lupus or rheumatoid arthritis. They assumed the body was just attacking its own tissues.
Okay, let's unpack this. Because the autoimmune theory makes intuitive sense at first, but the source notes make a very distinct pivot here.
They do. Fibromyalgia actually lacks the standard criteria for inflammation and tissue damage. Like
Yeah.
if you run an erythrocyte sedimentation rate or look for C-reactive protein,
The classic markers of an inflammatory cascade.
right, they typically come back entirely normal. The joints aren't degrading, the synovial fluid isn't inflamed at all.
What's fascinating here is the paradigm shift that this normal blood work forced upon the medical community. I mean, think about it.
Yeah.
If there are no autoantibodies destroying the joints, the pain isn't originating from a localized physical trauma. It forced researchers to realize this isn't a hardware problem with the musculoskeletal system.
It's not a broken bone or torn cartilage.
Exactly. It's a software problem within the nervous system.
Yeah.
The document specifically classifies it as a disorder of central sensitization.
Central sensitization. I think the best way for you listening to visualize the mechanics of this is like a faulty home security system.
Oh, that's a great way to put it. Right. Imagine your nervous system is the wiring for the alarms on a house. In a normal system, the alarm only triggers when someone shatters a window or kicks in a deadbolt.
Which represents acute nociceptive pain, like actual tissue damage.
Exactly. But with central sensitization, the threshold for that alarm is drastically lowered. The siren screams at top volume just because, like, a strayed leaf gently brushed against the front door.
That analogy perfectly captures the mechanism of allodynia.
Allodynia.
Yeah, which the source text highlights as a primary clinical feature. Allodynia is when a non-noxious stimulus, that leaf brushing the door, or in the patient's case, the weight of a shirt or a slight drop in room temperature.
Wow, just the weight of a shirt.
Yes, literally. It's interpreted by the brain as agonizing pain. The dorsal horn neurons in the spinal cord have essentially become hyperexcitable. They amplify normal sensory input into severe pain signals.
And that amplification also applies to things that are actually supposed to hurt, right?
Yeah,
Which the notes identify as hyperalgesia.
exactly, hyperalgesia.
So if a normal person bumps their shin on a coffee table, it's a localized temporary pain.
Right, it hurts, but you move on.
But for a fibromyalgia patient experiencing hyperalgesia, that same minor bump triggers a massive disproportionate pain response. The volume dial is basically stuck at 10.
It's exhausting for the patient.
But the document doesn't just describe the symptoms. It points to a very specific biological breakdown causing this faulty software. It comes down to the descending pain pathways, doesn't it?
It does. Our central nervous system doesn't just passively receive pain signals.
No, it doesn't.
No, it actively regulates them. The brain sends inhibitory signals down the spinal cord to dampen pain input, basically acting like a filter for background noise.
Okay, that makes sense.
And the source document notes that fibromyalgia involves a deficiency in central nervous system neurotransmitters that drive this inhibitory pathway.
Specifically serotonin and norepinephrine, right?
Yes. When you lack those key neurotransmitters, the descending pathways simply can't do their job. The filter is gone, and the brain is flooded with unfiltered, amplified sensory data.
Which completely explains why treating this like an inflammatory autoimmune disease was just a dead end.
Totally.
Like, pumping a patient full of corticosteroids to reduce inflammation won't do a single thing if the actual mechanism is a neurotransmitter deficiency in the nervous system.
Precisely. You can't fix a software glitch by putting a cast on the monitor.
That is such a good way to phrase it. But, this brings us to a massive clinical hurdle.
The diagnosis.
Yeah. I have to push back on the diagnostic process here. If a patient is experiencing this invisible software glitch diffuse multifocal pain that literally migrates around the body.
And comes and goes in unpredictable flare-ups.
Right. How does a doctor objectively verify it? Historically, if a patient reported severe migrating pain with absolutely zero biomarkers or visible tissue damage, they were just dismissed, weren't they?
Oh, constantly. That skepticism is exactly what patients faced for decades.
So how do we measure a migrating target without it just sounding like a total mystery illness?
Well, that's why the diagnostic criteria had to evolve so rigorously. The document details the 2019 updated criteria, which fundamentally changed how we quantify subjective pain.
How so?
It removes the guesswork and introduces strict mathematical thresholds. First, the symptoms must be present at a consistent severity for at least 3 months.
Okay, so ruling out just a temporary stress response or like a post-viral thing.
Exactly, and then they map it out systematically. The notes specify that pain must be present in at least 6 of 9 designated bodily regions.
6 of 9. What are the regions?
The head, the left and right arms, the left and right legs, the chest, the abdomen, the upper back, and the lower back.
Wow, that is specific.
It has to be. By requiring 6 out of 9 regions, the criteria ensure the pain is genuinely widespread and central.
Rather than just referred pain from, say, a single herniated disc.
Right, but they don't just stop at the geography of the pain. The notes also detail the use of the Widespread Pain Index, or WPI, and the Symptom Severity Scale.
And these are just arbitrary rate your pain from 1 to 10 type questions, right?
No, not at all. The Symptom Severity Scale forces the clinician to quantify the secondary impacts. Things like the level of cognitive dysfunction, what patients often call brain fog.
Right, brain fog.
And the severity of waking up unrefreshed, and the sheer level of somatic burden.
Because the somatic burden is what ultimately destroys the patient's quality of life. The text makes a really strong point to highlight how severely this syndrome interferes with ADL's activities of daily living.
It's paralyzing.
When your nervous system is trapped in a constant state of hyperarousal, processing false alarm signals from everywhere, the resulting central fatigue has to be overwhelming. We aren't just talking about feeling a bit tired after a long day at work.
No, we are talking about a systemic energy depletion where just standing up to cook dinner feels like running a marathon.
And the document makes another critical point about the 2019 updates that I want to mention. Fibromyalgia remains a valid diagnosis irrespective of other clinical diagnoses.
Yes, that's a huge update.
Meaning you can have rheumatoid arthritis, a
Right.
true inflammatory disease, and still develop the central sensitization software glitch of fibromyalgia on top of it.
They actually frequently co-occur. Chronic peripheral pain from an inflamed joint can trigger the central nervous system to become sensitized over time.
Wait, really? The physical pain causes the software glitch.
Yes, the constant barrage of real pain signals eventually damages those descending inhibitory pathways we discussed earlier, leading to secondary fibromyalgia.
That is brutal. So you have a patient whose nervous system is relentlessly misfiring, causing this widespread migrating pain and absolutely destroying their ability to perform basic daily tasks.
And since the origin is still technically unknown, as the notes admit, we can't cure the root cause.
So doctors have to target the symptoms. And one of the most debilitating secondary effects of a hyper-aroused nervous system is severe, intractable insomnia.
Right. The brain simply cannot power down to rest.
Which brings us to the medications. Here's where it gets really interesting. The notes go out of their way to explicitly classify zolpidem tartrate Ambien as a sedative hypnotic.
Yes.
And they deliberately state that it is not a benzodiazepine. For a long time, benzos like Valium or Xanax were the heavy artillery for shutting down the central nervous system, right?
They were the go-to, yeah.
So if zolpidem isn't a benzo, how exactly is it pulling off this profound sedation and muscle relaxation? How is it shutting the brain down?
It comes down to receptor specificity. Both benzodiazepines and zolpidem work by enhancing the effects of gamma-aminobutyric acid, or GABA.
Which is the primary inhibitory neurotransmitter in the brain, right?
Exactly. When GABA binds to its receptors, it opens chloride channels, hyperpolarizing the neuron and making it much harder for it to fire an action potential. It essentially just puts the brakes on neural activity.
But benzos are a bit of a blunt instrument compared to Ambien.
Very blunt. They bind broadly across multiple different GABA-A receptor subunits. That's why they cause that sweeping anti-anxiety, muscle-relaxing, and anticonvulsant effect all at once.
Okay, so they hit everything.
Right. But zolpidem is more like a sniper. It specifically targets the alpha-1 subunit of the GABA-A receptor.
Oh, I see.
By binding preferentially to just the alpha-1 subunit, it heavily isolates the hypnotic and sedative effects. It depresses the central nervous system at very specific levels.
Like the limbic, thalamic, and hypothalamic levels, according to the notes.
Exactly. The limbic system processes our emotional responses to pain. The thalamus is the massive relay station for all sensory input, and the hypothalamus governs our sleep-wake cycles.
If we connect this to the bigger picture...
Oh, wait, you stole my line.
I couldn't help it. But seriously, if we look at our fibromyalgia patient, their thalamus is overwhelmed, their limbic system is exhausted by chronic pain, and their hypothalamus can't initiate sleep. By selectively agonizing those alpha-1 GABA receptors, zolpidem forces a chemical blockade, right? It forces the sensory relay station to just shut up so the patient can finally get some sleep.
Well, if we connect this to the bigger picture, and yes, I'm reclaiming my line, this drug is doing the heavy lifting that the patient's depleted serotonin and norepinephrine pathways cannot do.
Just an off switch.
Exactly. It provides a highly targeted pharmacological off switch for a nervous system trapped in a feedback loop of hyperalgesia.
But hitting that off switch comes at a massive cost.
It really does.
The final section of the source document outlines the contraindications and adverse effects, and honestly, it reads like a thriller novel.
The side effects are intense.
First, the notes mention this fascinating paradox. Patients with a known hypersensitivity to benzodiazepines are contraindicated for zolpidem.
Even though it's not a benzo.
Right. We just established it's chemically distinct and highly selective. But the cross-reactivity at the GABA receptor site means if your body rejects a benzo, it's going to reject Ambien too.
It's a great example of why functional class matters more than just the molecular structure.
Yeah. But the precautions list goes way beyond just hypersensitivity. There's a whole list of warnings for pregnant or breastfeeding individuals, children under 18, geriatric patients.
And patients with a history of abuse, depression, or suicidal ideation.
Right. And because zolpidem depresses the central nervous system, it slows down autonomic functions. The notes require extreme caution for patients with respiratory disease or sleep apnea.
Because if you deeply depress the respiratory drive in someone whose airway already collapses during sleep, the results can be fatal.
The systemic load is massive. Caution is required for hepatic disease, obviously, because the liver has to metabolize the drug. But here's something that caught my eye. The notes explicitly highlight a dosing difference based on gender.
Yes.
It states that females generally require a significantly lower dose due to increased sensitivity. Why is the female nervous system interacting with this chemical differently?
Well, it's actually less about the nervous system itself and more about pharmacokinetics.
Meaning how the body processes the drug.
Right, specifically hepatic metabolism. Zolpidem is primarily metabolized by the CYP3A4 enzyme in the liver. Research has shown that women clear the drug from their systemic circulation much more slowly than men do.
Really? Why?
It's partly due to differences in enzyme activity and volume of distribution based on body composition. Treating a highly sensitive CNS requires extreme precision, and if you get the dose wrong, the drug lingers.
Meaning if a woman takes the standard male dose at 10 p.m., her liver hasn't cleared the active metabolites by the time her alarm goes off at 7 a.m.
Exactly. The document refers to this as next morning impairment. The alpha-1 GABA receptors in her thalamus and cortex are still heavily hyperpolarized when she wakes up.
So she's still under the influence.
Yes, her cognitive processing, reaction times, and motor skills are still operating under a sedative hypnotic haze when she gets behind the wheel of a car to drive to work.
Oh, so what does this all mean? We are prescribing a highly potent, highly selective CNS depressant to a patient population whose primary disease is an already malfunctioning CNS.
It's a very delicate tightrope walk of pharmacology.
It is. And when you look at the adverse effects listed in the document, I have to point out a glaring, almost cruel irony.
The myalgia?
Yes. Under the musculoskeletal adverse effects of Ambien, the notes list myalgia. Muscle pain. Wait, a drug often used to help manage fibromyalgia, a condition defined by muscle pain, has muscle pain listed as an adverse effect.
I know, it is the ultimate catch-22 in pharmacology. I totally validate your shock there.
A patient takes a drug specifically to escape the crushing muscle pain keeping them awake, and the drug itself induces myalgia. How does a sleep medication cause muscle pain?
It has to do with how sedative hypnotics alter sleep architecture.
Okay, walk me through that.
Natural sleep cycles through various stages, including deep, slow-wave sleep. Slow-wave sleep is the critical phase where the body releases human growth hormone and actively repairs muscle tissue.
Now, it's the healing phase.
Right. While zolpidem induces sleep onset quickly, it can alter the natural progression of these restorative phases. Furthermore, as the drug rapidly clears the system, because it has a very short half-life, the sudden drop in GABAergic inhibition can cause a mild rebound excitation in the nervous system.
Oh, wow.
Yeah, so the muscles never get their profound restorative repair phase, and the sudden withdrawal of the drug leaves them tense and aching.
That is brutal. You're essentially trading the pain of central sensitization for the pain of pharmacological sleep disruption.
Unfortunately, yes.
But the adverse effects don't stop at the musculoskeletal system. The systemic reactions include rare hematologic drops like leukopenia, a decrease in white blood cells from the systemic chemical load on the bone marrow.
There are severe gastrointestinal effects too, including anaphylaxis.
But the central nervous system effects are where things get truly wild. The document lists amnesia, depression, hallucinations, and what they call complex sleep-related behaviors.
Yes, the sleep behaviors.
They specifically highlight sleep driving and sleep eating. How was that even possible?
This is perhaps the most profound illustration of how specific receptor targeting works. Because zolpidem aggressively targets those alpha-1 subunits, it heavily suppresses the hippocampus.
Which does what?
It's responsible for memory consolidation, and it also suppresses the higher cortical areas responsible for conscious awareness.
So the memory recorder is unplugged and the conscious pilot is knocked out.
Yes, but the basal ganglia and the motor cortex, the areas that handle ingrained habitual sequences of movement like chewing, walking, or turning a steering wheel, are not fully inhibited.
Oh my God.
So you have a patient whose body is capable of executing complex motor pathways on pure autopilot, completely uncoupled from conscious oversight or memory formation.
You could literally get out of bed, walk to the kitchen, cook an entire meal on the stove, eat it, grab your car keys, drive down the street, and wake up the next morning back in your bed with absolutely zero memory of the event.
It happened.
Your consciousness was totally offline, but your motor functions were essentially sleepwalking on steroids. It is terrifying to realize how compartmentalized the brain really is.
It really makes you respect the chemistry.
Definitely. Well, let's take a breath and briefly recap this journey for you listening. We started with the invisible, migrating pain of central sensitization.
Discovering that fibromyalgia isn't an autoimmune hardware issue, but a software glitch driven by neurotransmitter deficiencies.
Right. Then we explored the strict math required to diagnose it. The 6 of 9 regions, the widespread pain index bringing objective measurement to a highly subjective experience.
And finally, we ventured into the heavy-hitting pharmacology used to treat the secondary symptoms.
Unpacking how sedative hypnotics like zolpidem provide a desperately needed off switch, but come with massive, sometimes paradoxical risks from myalgia to the mind-bending reality of sleep driving.
There's one final thing I want to leave you pondering today.
Let's hear it.
Throughout this deep dive, we've seen that a condition like fibromyalgia can alter the brain so much that a gentle touch is interpreted as agonizing pain. Your reality tells you that you are being destroyed even when your tissues are perfectly fine. Meanwhile, a tiny pill like zolpidem tartrate can alter consciousness so profoundly that a person could drive a car or cook a meal while entirely asleep.
Completely decoupling awareness from action.
Exactly. It forces you to wonder if our perception of physical reality and our very consciousness can be so easily rewritten by invisible nervous system glitches and targeted chemicals. How much of our everyday reality is just a fragile chemical illusion?
Wow. That is a haunting thought to end on. If our baseline reality is that fragile, then yeah, how much can we really trust it? Thanks for joining us on this deep dive into the source material. We'll see you next time.